Heart disease is one of the most important diseases affecting the New Zealand population today. Let's begin with thinking about myocardial infarction. As we've learned in the episode on vessels, coronary artery occlusion causes arterial territory myocardial infarction. This usually occurs due to rupture of an unstable plaque with an overlying thrombus. Here in the illustration you can see the thrombus, which is the dark part, and the plaque, which is the white part. A myocardial infarction doesn't happen all at once. The first thing that happens in the first 30 minutes is a subendocardial infarction develops. As further time passes, the infarction extends through the full thickness of the wall. Time is muscle is the clinical saying. Lysis of the thrombus saves myocardium because it doesn't happen all at once. If we can intervene after half an hour, we save most of that myocardium. An important concept is that each artery supplies a specific territory, so we can tell where the infarct is through the ECG, because we know a specific part of the heart is being affected. Have a look at the diagram. Remember that the left anterior descending affects mostly the anterior part of the heart, but in some people they are right coronary artery predominant, and the right coronary artery area can be much more extensive. An important thing to remember is the progression of the infarct. You can see absolutely no changes at all in the heart muscle until about 1 day. Then, at 24 hours, what we get is infiltration of neutrophils into the myocardium. These persist for up to 3 days, and after 3 days, the predominant cell type becomes macrophages. They chomp up that necrotic heart tissue and activate fibroblasts. So about 10 days we start to get fibrosis and granulation tissue, which then progresses over several weeks to a scar. All this is covered in much more detail in Cloud. It's a great exam question, so study it in detail. The histologic changes relate to the complications of MI. Initially, during the first day, when we can see no changes, arrhythmia and contractile dysfunction are the main causes of death. About days 2 and 3, pericarditis can develop. This is because all the neutrophils can extend onto the surface of the heart. We can hear the rub. There's a whole lot of fibrin there. About days 3 to 7, the myocardium is really soft. Those macrophages are chomping up the dead tissue. It's at this phase that myocardial rupture can occur. The rupture can occur through the wall into the pericardium, giving a hematopericardium, which stops the heart filling up and can cause sudden death. Perhaps the rupture might occur through the septum, giving rise to a big blood shift from left to right. About 8 to 10 days, the healing starts occurring. There's granulation tissue, and the inside of the heart becomes really, really sticky. A mural thrombus can occur. This can embolize, giving rise to stroke, kidney infarction, all the places emboli go to. Finally, when the heart is healing by scarring, a very, very thin scarred remnant can develop. This can pop out, forming a bulbous aneurysm, or it can cause long-term heart failure. Now we're going to consider each of these complications in turn. The early MI complications, arrhythmias, happen in the first 48 hours. The most common is ventricular fibrillation. Reperfusion, in other words, when the clot is lysed, frequently induces arrhythmias. If a large part of the heart is lost due to myocardial infarction, it can induce cardiogenic shock. This means the heart just stops contracting and you get acute heart failure. The mural thrombus over the infarct can develop at approximately 8 to 10 days, especially in those who don't have initial thrombolytic treatment. With time, the thrombus becomes organised and adherent due to ingrowth of granulation tissue from the wall, which is organising granulation tissue at this point. Emboli can lead to cerebral infarction. Here's a picture of an inflamed pericardium. It's classically described as bread and butter pericarditis. Imagine two pieces of bread spread with butter or margarine. You pull them apart and it kind of has that oddly patterned peaked look. That's what the pericardium looks like. There's two kinds of pericarditis that happen in myocardial infarction. The one that happens immediately 2 days after the MI, and then the second one known as Dressler's syndrome, where the inflammation in the pericardium induces an autoimmune response. This is where the heart has ruptured, leading to a massive accumulation of blood in the pericardium. The arrow is pointing to the rupture. The technical name for this is pericardial tamponade. Tamponade because the blood prevents the heart from expanding during diastole, which leads to sudden cardiac failure. Let's move on from myocardial infarction and think of the other things that injure the heart. These things fall into a category called cardiomyopathy. And when the heart's injured, it can respond in three main ways. It can be injured and stop contracting, in other words, become dilated and enlarged. It can become hypertrophic and thickened, or it can become restrictive, so it tries to expand and contract, but just can't because it's really, really stiff. Let's think about some diseases that we find in cardiomyopathy. Dilated cardiomyopathy is mainly caused by three things. The first is ischemic heart disease. So imagine if there's just a little bit of ischemia happening all the time, or a large bit of ischemia affecting a large part of the heart. It's not going to contract properly and the heart dilates. The second kind of dilated cardiomyopathy is due to viruses, which kill and disable myocytes, and the third common one is alcohol, which again kills and disables myocytes. Acute viral myocarditis is a cause of sudden death in young adults. It's caused by two main viral types, Coxsackie B or echovirus. People feel generally unwell, go to bed and don't wake up. Why? Because there's extensive myocyte death and fibrosis being caused by the virus. Here we have an autopsy picture of someone who's had viral myocarditis. They have a massive lymphocytic infiltrate into the myocardium. It prevents the myocardium from contracting, hence sudden death. It's not all bad news. About 50% of patients get complete recovery from myocarditis. Some patients develop chronic myocarditis with fibrosis and result in dilated cardiomyopathy. This is a common reason for cardiac transplantation. Alcohol is one of the most frequent causes of toxic cardiomyopathy. The other cause is treatment due to chemotherapy. To get chronic cardiomyopathy from alcohol, chronic use is needed. It is, however, reversible with abstinence. Alcohol can directly inhibit mitochondrial oxidative phosphorylation and fatty acid oxidation, poisoning the cells directly and causing cell death. After cell death, fibrosis can occur. The classic disease for hypertrophic cardiomyopathy is hypertension, but there's also an important genetic disease, hypertrophic cardiomyopathy. In this heart, you can see the result of poorly controlled hypertension. Note how thick the wall is and how small the lumen is. This is because the heart has been pushing blood at high pressure out through the aortic valve. Chronic aortic stenosis would also give a concentrically hypertrophied heart like this one. Microscopically, we can see the heart muscle becomes hypertrophic in each individual fibre. This is shown in this picture by the really large nuclei developing in the fibres. In addition, we get fibrosis between the fibres because there's a relative ischemia happening because of the really thick muscle. This picture shows hypertrophic cardiomyopathy, the inherited condition. Note that this isn't concentric cardiomyopathy. The hypertrophy preferentially affects the septum. Thus, we can get occlusion of the outflow of the heart. The microscopic changes are similar. We get large nerve fibres and fibrosis, but they're really disorganized. Let's think about why that might be. The reason that they're poorly organized muscle fibers is that in this autosomal dominantly transmitted disease, there are mutations in one of the 4 genes encoding proteins of the cardiac sarcomere. As the sarcomeres don't form properly, the actual myocytes become disorganized inside and link to each other abnormally. The third category of cardiomyopathy is restrictive cardiomyopathy. The wall becomes really stiff so it can't go in or out. Quite often that's due to something infiltrating the wall. A common thing that can infiltrate the wall of the heart is amyloid. So amyloid can be produced by multiple myeloma, where it deposits widely around the body, including the kidney, but also in the heart. The second type of amyloid that exists is secondary amyloidosis. It happens in old people due to generalized chronic inflammatory processes. The restriction caused by replacement of normal myocardial contractile elements by these amyloid deposits prevents the heart from either expanding or contracting. Here in this picture, you can see the pale pink amyloid deposited between the myocytes and preventing their contraction. In this picture here, you can see granulomas. That's because the heart has sarcoidosis deposits in it. Sarcoidosis is a granulomatous inflammatory disease. We think of it primarily affecting the lungs, where it can cause a restrictive lung disease. But you can also get granulomas in the heart, where it causes restrictive cardiomyopathy. Hypertension is a very common disease in our society, and it causes changes in the heart, blood vessels, and many organs around the body. We can think of hypertension as being either essential or primary hypertension, which is lifestyle and perhaps genetic, and then secondary hypertension due to a really well-defined cause, such as renal hypertension, endocrine hypertension, vascular hypertension from coarctation of the aorta, or neurogenic hypertension from things like raised intracranial pressure. Hypertension can affect many organs around the body. Large blood vessels, as we've discussed, with atherosclerosis and its many complications, small blood vessels, the heart with hypertensive cardiomyopathy and ischemic heart disease, the kidney with benign nephrosclerosis, the eyes with hypertensive retinopathy, and the brain with hemorrhage and infarction. Let's consider some of these. This is a small vessel in the kidney of someone who has hypertension. Normally, the lumen would be 10 times this big. Hypertension has caused this onion skinning pattern, where we get massive increase in the smooth muscle around this small arteriole, which has constricted the lumen to a pinpoint. This kidney is suffering from hypertension. It's caused microscopic infarcts all through the kidney. It gives rise to this really leathery granularity. Here's a brain showing the circle of Willis. Cerebral blood vessels are thin-walled. They're end arteries, which means they come directly off quite high-pressure vessels. And they have a special weak join, often in some people, where they branch. So this can give rise to many special features of hypertension in the brain. Berry aneurysms can cause subarachnoid hemorrhage. They're due to a congenital weakness where the vessels join, but hypertension makes this congenital weakness blow up like a balloon. Here we have an infarct in the brain. In particular, it's in the pons. Pontine infarcts happen because of hypertension. The end arteries come off a high-pressure supply and get advanced atherosclerosis in them. The hypertension then just makes them pop, and we get bleeds into the internal capsule. The arrow here is pointing to the infarct in the internal capsule caused by hemorrhage. Here the atherosclerosis has caused an ischemic stroke, so maybe an embolism from atherosclerosis has broken off, or maybe a bit of atherosclerosis in the cerebral vessel has had its plaque rupture and a thrombus form, just like in the heart. Chronic hypertension can also lead to arteriolosclerosis of the deep penetrating arterioles of the brainstem. This can cause little tiny infarcts called lacunar infarcts. They occur here in the pons, but also in the basal nuclei, such as the lenticular nucleus and the thalamus. This is a retina with hypertensive retinopathy. Here you can see the proteins that have leaked from the vessels being shown by the red arrow. We get vascular proliferation, changes in the shape and the reflection of the arterioles, and these can be graded. In grade 1, we just have thickening of the arterioles. In grade 2, we can see venous constriction where the arteries cross the veins. In grade 3, we get these dot hemorrhages, blot hemorrhages, and ischemia causing these cotton wool deposits. And in grade 4, we can get papilledema. Malignant hypertension is a special case of hypertension. It can occur in any situation where there's rapid increase. It can be seen, for example, in postpartum hypertension. Rapidly progressive organ damage occurs. There's arterial necrosis and thrombosis. This can happen in the kidneys, giving rise to renal failure, in the brain, giving rise to hypertensive encephalopathy, and in the coronary arteries, giving rise to left ventricular failure. Today we've been thinking about cardiac pathology. We've thought about myocardial infarction, cardiomyopathy and hypertension. These and other topics will be covered in your Cura Cloud tutorial. A good time to do it would be just now.